Hello, everyone. We'll get started promptly at 2 p.m. Don't mind me for right now. I'm just setting up the stream on LinkedIn and YouTube. Hello, everyone. We'll get started promptly at 2 p.m. Don't mind me for right now. I'm just setting up the stream on LinkedIn and YouTube. At 2 p.m. Don't mind me for right now. I'm just setting up the stream. All right, everyone. Thank you for joining us. We'll be getting started briefly in about 5 minutes. All right, good afternoon, everyone, and welcome. My name is Javier Amador Castañeda, and I am a respiratory care practitioner at Columbia University Irving Medical Center in New York. And I am also the co-chair of the SCCM ARDS Innovation Knowledge Education Group. And on behalf of my co-chair, Dr. Bruce Ramina, and the entire CAC leadership, thank you for joining us on today's session, which is the evolution and future of ARDS from global definitions to precision medicine. We're streaming simultaneously on Zoom, on LinkedIn Live, and YouTube Live, maximizing global reach. If Zoom reaches capacity, please continue via our social media channels. We encourage questions throughout. Post them in the Zoom Q&A or comment on LinkedIn or YouTube. Our team will collect them for discussion during the Q&A chat. We're honored to host two world leaders in ARDS research and care, Professor Michael Matthay and Professor Carolyn Calfee. So now I am pleased to introduce today's guest moderator, Dr. Denise Battaglini, who will be guiding our discussion and facilitate transitions. Dr. Battaglini, thank you for being with us, and if you can please introduce yourself and any disclosures that you may have.
Thank you, Javier. It's an honor to moderate with you this session, this webinar today. I'm Denise Battaglini. I'm assistant professor at the University of Genova. I'm the ECM representative for Italy, finishing my mandate at the end of October. I work as consultant in anesthesia and intensive care at the Polyclinic San Martino Hospital in Genova, and I earned my medical degree followed by the residency at the University of Genova, 2 fellowships in respiratory and critical care medicine at the University of Barcelona, Spain, and University of Rio de Janeiro. That I earned a PhD in translational medicine at the University of Barcelona, Spain. I will be introducing our distinguished speaker today. Dr. Michael Matthay is a critical care specialist and serves as a UCSF's Associate Director of the Critical Care Medicine. With the major support of the National Institute of Health, his research focuses on developing novel therapies for acute respiratory failure in critically ill patients, particularly those patients with sepsis. Over the past 20 years, his work has contributed to several major therapeutic advances. Dr. Matthay earned his medical degree from the University of Pennsylvania, followed by residency in internal medicine at the University of Colorado, Denver, and a fellowship in cardiovascular pulmonary medicine and pulmonary disease at the UCSF. He also completed a cardiology fellowship at the UCSF Cardiovascular Research Institute. Passionate about education, Dr. Matthay has mentored countless physicians and faculty members, receiving the UCSF Lifetime Achievement in Mentoring Award in 2013. In 2014, the American Thoracic Society awarded him the Trudeau Medal for lifelong contribution to research, teaching, and patient care. So beyond the medicine, he is an open water swimmer, outdoor enthusiast, and lifelong baseball fan. So today, Dr. Matthay will take us on a journey through the history of ARDS definitions, examining their strengths and limitations, and will guide us toward the rationale and evidence behind the 2023 Global Consensus definition of ARDS. Please join me in welcoming Dr. Matthay.
Thank you very much. Thank you very much, Dr. Battaglini. That was an overly generous introduction. I'm pleased to participate. And the title for my discussion is Beyond Berlin, the Global Definition of ARDS. I believe we'll have time for questions and comments after both my talk and Dr. Calfee's, and I look forward to a good discussion later. Here are my disclosures, and I have no conflicts for this presentation today. And here's my plan. I want to give a case presentation to illustrate the need that we felt prompted a new definition. And I'll focus briefly on the North American European 1994 and then the Berlin 2012 definitions, and then the clinical context and rationale for an expanded definition of ARDS, and then finally the new global definition of ARDS and its relevance today. So here's the case presentation. 21-year-old woman presented with 6 days of intermittent subjective fever and chills and dark urine. Her social history is that she was born in India and lived there until age 18. Her travel history was that she visited India in May of 2023. She presented with a high fever of 103, heart rate of 130, hemoglobin 11.2, white blood cell count of 3,200, a platelet count of 52,000. And initially, when she presented, her oxygen saturation was 98% on room air. Because of her travel history and background, a blood smear was done, which revealed a positive rapid malarial antigen, as you can see on this slide. Now, on this slide on the far left is her initial chest radiograph when she presented on day 1, when she was just using room air, no supplemental oxygen, and the chest radiograph is clear. However, on day 2, you can see the development of bilateral opacities, both lung fields quite involved extensively, and at this point, she was being treated with high-flow nasal oxygen. Her CT scan on that same day showed extensive bilateral ground glass opacities, likely representing ARDS or non-cardiogenic pulmonary edema, according to the radiologist. Her respiratory support consisted of high-flow nasal oxygen, 30 liters per minute, an FiO2 of 0.7, a PaO2 of 79 millimeters of mercury, and a PaO2-FiO2 ratio of 112 millimeters of mercury. So the question is, does this patient have ARDS? Well, she had acute onset over 7 days with a risk factor that was not primarily cardiogenic. So yes for that. Bilateral opacities on the chest radiograph and the CT scan, clearly yes. A PaO2-FiO2 ratio less than 300, for sure, yes. But she was not mechanically ventilated with at least 5 centimeters of water a PEEP. So no by the 2012 Berlin definition. So let's look back then at the 2 definitions that we had been operating with for the last 30 years. First, the North American European definition, in which acute lung injury was the designated term for patients with a PF less than 300, but greater than 200. And the term ARDS was reserved for patients with a PF ratio less than 200. Now, the Berlin definition, published in 2012, consolidated the term ARDS for all patients with a PF less than 300 millimeters of mercury. Plus, importantly, it added the use of echo to help rule out cardiogenic pulmonary edema, and also valuable, more specific chest radiographic criteria. Now, we had a lot of progress in important major clinical trials that were done based on a definition of ARDS in which the patient was intubated and ventilated. As you can see in this chest radiograph, where the yellow arrow is pointing to the endotracheal tube. And the ARMA low tidal volume trial, published in the New England Journal of 2000, of course, included patients who were intubated and ventilated. So did the FACT trial, the fluid conservative trial in the New England Journal in 2006, and also the PROSEVA trial, which tested proning in patients with a PF less than 150 millimeters of mercury, published in the New England Journal of 2013. So these are 3 seminal trials that made a big difference in clinical practice that were done in patients who were ventilated with a diagnosis of ARDS. Now, the Berlin definition also provided oxygen cutoffs that were associated with different mortality rates. Those cutoffs are listed on the right on this slide. Mild PF is 200 to 300, moderate 100 to 200, and severe PF less than 100. And you can see with the lines here on the x-axis up to 28 days, and the y-axis, the probability of hospital survival, that those patients in blue with mild versus those patients in moderate versus those patients severe had different mortality outcomes. So this proved to be useful in several observational studies and other reports. However, should ARDS really be defined by the presence of an endotracheal tube with positive pressure ventilation? Well, in the original publication in JAMA, even Derek Angus, who wrote the editorial regarding the Berlin definition, pointed out this limitation, namely the Berlin definition did require the presence of an endotracheal tube. And it's also interesting to think back that animal and various experimental studies of lung injury, which Carolyn and I and others reported, in the majority of these experimental models of ARDS, they were done actually in the absence of an endotracheal tube in animal models that were not ventilated. So what changed since the 2012 definition that prompted us to think about expanding the definition? Well, first, there was the increasing use of high-flow nasal oxygen for acute hypoxemic respiratory failure. Secondly, a growing recognition that the SF ratio is a reliable surrogate for the PF ratio. And third, importantly, a recognition of limitations of the Berlin definition for resource-limited settings in the world. And so it's worth, I think, a moment to review the original trial from France, the Frat et al. Trial, published in the New England Journal in 2015, on the value of high-flow oxygen in acute hypoxemic respiratory failure. Now, this was a very important trial that transformed our field, and it included 310 patients. Respiratory rate was greater than 25 per minute. PF had to be less than 300 millimeters of mercury. PCO2 had to be less than 45 millimeters of mercury to exclude patients with just hypercapnic respiratory failure, i.e. no chronic respiratory failure. And pneumonia was the most common cause. Well, as most everyone knows, the results of this trial were quite dramatic. It turned out that the high-flow nasal oxygen was associated with increased survival compared to standard oxygen therapy and non-invasive positive pressure ventilation. And this had a major effect in our field. And then when the pandemic hit in 2020, the use of high-flow nasal oxygen was widespread throughout the world. And this prompted my friends and colleagues, Taylor Thompson and Lorraine Ware and I, to publish this opinion piece in Lancet Respiratory Medicine in April of 2021, in which we suggested that consideration should be given to revising and updating the Berlin definition, potentially to include patients with high-flow nasal oxygen, and consider perhaps the use of ultrasound to diagnose bilateral pulmonary opacities, not to depend on chest radiograph or CT scan, and also to consider a formal adoption of the SF ratio as an alternative to the PF ratio. And so because of this and interest around the world, we organized a global consensus conference. And this slide shows the 32 members of this conference, including right in the middle, Carolyn Calfee, and many other experts around the world with considerable diversity, geographical representation. We had a patient advocate, we had a respiratory therapist. You can never have everyone that you want, but the 32 members seem to be a workable number. And we met 6 times formally in Zoom conferences, and then several subgroups met. And the major goals of this global consensus conference group was to answer these questions. Should intubation or non-invasive ventilation be required for a diagnosis of ARDS? Is the SF ratio an adequate substitute for the PF ratio for assessing hypoxemia? And can ultrasound be used to diagnose bilateral alveolar infiltrates? Now, let's think a little bit about the pros and cons of adding high-flow nasal oxygen equal to or greater than 30 liters a minute to the ARDS definition. On the left are the advantages. It focuses on patients requiring high levels of oxygen, regardless of the presence of an endotracheal tube. accounts for the evolution of clinical practice in the widespread use of high flow, which, as I indicated, and we all know, is a major therapeutic modality throughout the pandemic. It could facilitate enrolling patients in trials at an earlier stage, and endpoints could include progression to intubation. Also, it would facilitate studies of early ARDS and the natural history of ARDS. The disadvantages potentially would be that it could be challenging to estimate the fraction of inspired oxygen, although the FiO2 was successfully calculated in the French FRAT trial and in others. Is the cutoff of equal to or greater than 30 liters per minute optimal? Would 20 liters be better? Well, we discussed this and ended up favoring the 30-liter cutoff. It might include patients with better clinical outcomes than the Berlin definition. And what can we do to apply the high flow nasal oxygen resource limited areas where high flow is not available? So we had to cope with that issue. Should the diagnosis of ARDS depend on an arterial blood gas? Well, the SF ratio as a surrogate for the PF ratio in ARDS was introduced by Todd Rice and his co-investigators in 2007. It's derived from the linear equation shown here, quite straightforward, easy to calculate. And with this approach, mild ARDS is defined as an SF less than 315. Moderate ARDS is an SF less than 235. Because of the shape of the oxygen, the hemoglobin oxygen saturation curve shown here, the SpO2 must be no greater than 97%. Now, interestingly, there's a very good study published in Chefs in 2015. And in this study, the investigators tested the value and the accuracy of an SF ratio compared to a PF ratio for diagnosing ARDS. And you can see the consort diagram on the left. And if you go all the way down to the bottom, you can see that 238 patients were diagnosed by the PF ratio and 124 patients diagnosed by the SF ratio. Now, the 34% of the MICU patients were diagnosed with an SF ratio. Baseline illness, including comorbidities and severity of illness, were similar. Ventilator-free days, length of hospital stay, and mortality, 36% in both groups, were the same. And in fact, the SF ratio correlated with mortality better than the PF ratio in the severe group. Now, what are the pros and cons of adding the SF ratio to the ARDS definition? Well, the advantages are listed on the left. Continuously available, highly sensitive for hypoxemia, easily interpretable, non-invasive, no risk for procedural complications, and more readily available in resource-limited settings and outside the ICU. Disadvantages are measurement error increased if the patient has poor perfusion, vasopressors in some cases, severe hypoxemia, or potentially acidemia. And there is the potential for misclassification of the diagnosis or severity in ARDS. And there is also the potential for reduced accuracy in patients with darker skin pigmentation. Should ultrasound be allowed for the detection of bilateral opacities? Another major issue. Well, ultrasound does have evidence for good diagnostic accuracy for alveolar filling and consolidated lung in patients with ARDS using these criteria: bilateral worsening or loss of lung aeration defined by equal to or greater than 3 B lines per image between two ribs and or consolidations bilaterally. And these are some references, including an excellent commentary by Dr. Ware in the Blue Journal in 2023. So then our other issue that we had to cope with is how can a revised and a new global definition apply to resource-limited areas of the world? Well, we had the advantage of having Dr. Beth Riviello, professor at Beth Israel at Harvard, work with us. And she had published a study on the hospital incidence and outcomes of ARDS in Kigali, Rwanda, in which she used a modified definition in 2016. Note there was a very high mortality of ARDS. And because arterial blood gas analyzers were not routinely available, she used the SF ratio. And because chest radiography was not routinely available, she used chest ultrasonography. And interestingly, the sensitivity and specificity of the Kigali modification was 96% and 86% respectively, even in a highly resourced setting, in a study published that I'm referencing here in Intensive Care Medicine in 2018. So our global consensus group discussed this at great length. We thought that formal adoption of the Kigali modification would allow for a better estimation of the true global burden of ARDS and implementation in clinical trials. So here are the major recommendations for the global definition of ARDS. First, expand the Berlin definition to include high-flow nasal oxygen with a minimum flow of 30 liters per minute. Add the SpO2-FiO2 ratio as an alternative to the PaO2-FiO2 for the oxygenation criteria. Allow the use of ultrasound with a well-trained operator to diagnose bilateral opacities, and to apply the Kigali modified definition for ARDS to diagnose ARDS in resource-limited settings, and not to require a PEEP or a minimal level of oxygen delivery, in part because of the lack of mechanical ventilators and the lack of reliable oxygen delivery systems. So, has the global definition, what can we say about the impact of the global definition at this time? It's only been a little more than a year and a half since it was published, but the global definition of ARDS has been adopted by the NIH ARDS Pneumonia Sepsis Consortium that is prospectively enrolling 4,000 patients through the year 2028. And in fact, almost 1,500 patients have been enrolled so far, and this includes about 20 hospitals in the United States. The global definition of ARDS was incorporated also into 2 prospective studies testing real-time biology in the UK, the FIND trial, and in the US, the SPARK study. And approximately 30% of ARDS patients were enrolled with high-flow nasal oxygen. And then importantly, a major phase 3 trial of mesenchymal stromal cell exosomes for ARDS, sponsored by Direct Biologics, expanded to include the global definition of ARDS. In the first round, it had only included intubated patients by the Berlin definition, and they applied to have it expanded to include the global definition, and importantly, the FDA approved this. The global definition of ARDS will be incorporated in the Panther trial, which Dr. Calfee will discuss in her talk. And the Kigali definition was adopted and implemented in a clinical trial in Africa, as I'm going to show you on the next slide. This is a trial of high flow versus standard flow oxygen delivery that is being led by Beth Riviello, but includes many investigators, as you can see, many of them listed here, some in sub-Saharan Africa and others from the United States. This trial is going very well and is evidence of the potential value of the Kigali definition being incorporated into the global definition of ARDS. And my last slide is just a figure to illustrate the potential impact of the global definition of ARDS with patient examples. So at the top left, you see a 68-year-old gentleman with abdominal sepsis, septic shock, and acute hypoxemic respiratory failure. He's intubated. There's an intratracheal tube in place. His oxygenation is shown here. He's ventilated with an FiO2 of 0.5, PaO2 75, and a PAF ratio of 150. So he is classic intubated ARDS, moderate, a typical patient included in the prior Berlin definition, but still included in the global definition. The second example is a 50-year-old woman with a history of breast cancer, COVID-19 pneumonia, and worsening shortness of breath for the past 6 days. You can see her chest radiograph, but she is not intubated. She's being managed with high-flow nasal oxygen at 40 liters per minute, an FiO2 of 0.8, oxygen saturation 91%, and an SF ratio of 114. So this is an example of a new category in the global definition. This is non-intubated ARDS. And the final example is on the lower left, a 39-year-old gentleman with abdominal sepsis and gram-negative bacteremia in a small, under-resourced hospital without blood gases, radiography, or mechanical ventilation. And you can see here the ultrasound images of his right and left lung that show the B lines and the criteria for bilateral consolidations. His supplemental oxygen was delivered by face mask at 15 liters per minute. FiO2 is 0.6. Oxygen saturation was 85%. So his SF ratio was 142. So this is an example of ARDS in a resource variable or limited setting, a new category in the global definition consistent with the Kigali definition. So I'm going to end there, but I believe we're going to have questions and comments after Dr. Calfee's talk. So I'll stop sharing, and then I think I leave here to allow Dr. Calfee to come in.
Many thanks, Professor Michael Matthay. Really and truly excellent talk. A reminder that we will address questions together at the end. So next, I'm delighted to welcome our second speaker, Dr. Carolyn Calfee, professor in residence of medicine and anesthesia at the UCSF, where she attends the intensive care units at Moffitt Lung Hospital. Dr. Calfee received her undergraduate degree from Yale and her medical degree from the University of Pennsylvania before completing her residency, chief residency, and pulmonary critical care fellowship. She also earned a master's in clinical research in 2009. Her primary academic focus is the prevention, diagnosis, prognosis, and treatment of ARDS and sepsis. She's internationally recognized for her pioneering work in molecular phenotyping of ARDS, advancing the concept of precision medicine in the ICU. Her research program also explores the impact of tobacco smoke and novel products on acute lung injury and the development of novel treatment for ARDS and sepsis. Dr. Calfee is an active member of the UCSF Centers for Tobacco Control Research and Education, the Cardiovascular Research Institute, and the UCSF Center. She has authored landmark studies shaping our modern understanding of ARDS, sub-phenotypes, and therapeutic strategies. Today, Dr. Calfee will present the future of ARDS, precision medicine, and promising trial ahead, highlighting how these innovative strategies may transform care for critically ill patients in the years to come. Please join me in welcoming Dr. Calfee.
Thank you so much, Dr. Battaglini. It was an incredibly kind introduction, and I really appreciate the opportunity to be with you here today. I hope you can see my slides okay. I'm going to be talking about the future of ARDS, precision medicine, and promising trials. These are my disclosures, and I'm not going to be talking about any products made by these companies in the talk today. So Dr. Matthay eloquently described so much progress that we have made in the past nearly 60 years since ARDS was first described. But one area in which we have really not made much progress is in identifying specific targeted therapeutics. These are just some of the many drugs that have appeared incredibly effective in treating mouse ARDS, but have failed, or in the case of corticosteroids, perhaps been inconsistent when translated into clinical trials for humans. And so we really have to think about not just doing the same thing over and over again if we want to see different results. Another problem is that we study syndromes, not diseases. And again, as Dr. Matthay just eloquently described, these definitions of ARDS that we have developed have been exceptionally useful in really transformative advances in supportive care for our patients. But these are not specific pathophysiologic entities. And in fact, whereas we think of ARDS in one syndromic bucket and sepsis in another, of course, in fact, many of our patients have both, and there's quite a bit of overlap and heterogeneity within these syndromes. And so this begs the question of whether some of this heterogeneity is contributing to our inability to identify effective targeted therapies. It's an age-old sort of conundrum in medicine, right? Should we be lumping or should we be splitting? And the question here is, if we split a bit more effectively within ARDS, might we solve our problem? Now, this approach, splitting or precision medicine, has had a lot of success in other fields of medicine. If we think about just the idea of treating patients based on biologic phenotype, and we'll talk about other types of splitting, but if we just think about the biologic phenotype, we can think about, for example, hormone receptor status in breast cancer, right, which has transformed the treatment of that disease. BRAF receptor status in melanoma, or a little closer to home for us pulmonologists, Th2 high versus Th2 low asthma. These approaches of stratifying patients based on the underlying biology within a broader syndrome have been very effective. And so the question is, could such an approach help us in ARDS? Now, if we think about how do we split rather than lump, there are lots of different ways that have been proposed over the years to split ARDS. And this actually goes way back to the original definition of ARDS in 1967 in The Lancet, where they were trying to grapple with some of these questions, right? We can split on the basis of severity. We can split on the basis of pulmonary, non-pulmonary, focal or non-focal chest radiographs. We could split on the basis of a variety of different biological dimensions that we know characterize the syndrome. I think all of these may be useful in different contexts, but I think what we're really looking for is groups that respond differently to treatment, right? Because that's what may enable us, those of us who care for patients, to actually deliver a better match for therapy if we can identify groups that respond differently to treatment. So I'm going to show you a data-driven approach to identifying subtypes of ARDS that we've been working on for about the past decade or so. And that's one that's called latent class analysis. And I'll go through this relatively quickly because I don't want to get too bogged down in the stats, but I want you to understand the broad concept, which is that this is a type of analysis that asks whether there are distinct subgroups or subclasses within a broader group of patients. So if you see this data distribution on the right-hand side in the black line, does that data distribution better fit with the hypothesis that this is one homogeneous class? Or maybe, as you can see here in the red or blue, two classes or three or four? And it actually can test a hypothesis about the best fitting number of classes. Now, this can be totally independent of clinical outcomes and actually just focused on the patient characteristics when they come into the ICU, which is how we used it in our analyses, and not driven by treatment response. So it's really just looking at the patients as they come in and saying, is there evidence here that there are distinct subtypes? And so when we have applied this in ARDS to a combination of clinical data and plasma biomarker data, we see consistently across many different studies two distinct phenotypes in patients with ARDS. These phenotypes are really characterized largely by differences in inflammatory biomarkers in their plasma, and so that's why we've called them hyperinflammatory and hypoinflammatory. They have very widely divergent clinical outcomes. They've now been replicated in more than 12,000 patients, adult patients, pediatric patients, randomized controlled trials and cohorts. And importantly, in secondary analyses of randomized controlled trials, they seem to respond differently to some treatments. And that is, again, why we're searching for these distinct subsets is because we're looking for better ways to treat our patients. And I'll show you a little bit of this data moving forward. This slide shows the continuous variables that are used to identify the phenotypes along the x-axis, sorted by the maximum differences at either end of the graph. So on the left-hand side here are the variables that are much higher in that hyperinflammatory phenotype. And we have inflammatory biomarkers like interleukin 6 and 8, TNF receptor 1, PI1. On this other extreme are the variables that are much lower in that hyperinflammatory phenotype, bicarbonate, so these patients are acidotic, protein C, so they have disordered coagulation, and systolic blood pressure, so they're more frequently in shock. And we see that consistently across a number of different studies, that hyperinflammatory phenotype is about a third of the patients. This slide shows mortality by phenotype in a number of different randomized control trials and observational cohorts. And I definitely don't expect you to read all of these, but just note that each row is a different study. Focus here on the years of enrollment, where you can see that these studies span from the mid-1990s all the way to the mid-2010s. And then if you see here on the right-hand side, this is the mortality in the two phenotypes. And you can see that consistently that hyperinflammatory phenotype has a dramatically higher mortality compared to hypo. Even in pediatric ARDS, where fortunately the mortality is much lower than in adult populations, even there we see it conveys a worse prognosis. So that's interesting and fine, but to be frank, there are lots of ways to prognosticate in our ARDS patients, so maybe not that useful. Let's get into this different responses to treatment, because that's where I think there may be ultimately some potential clinical utility here. So we first looked at this in the alveoli trial, which you may remember compared a high to a low PEEP strategy in 549 patients, found no difference in mortality. That was published in the New England Journal. And we asked, okay, well, is there any evidence of response to the PEEP within either phenotype? Because the PEEP was randomly assigned here, so we can test for this question. And what we found was what's called a significant interaction for 90-day mortality. It's also known as effect modification. And that just means that the effective PEEP was significantly different in the two phenotypes. So if you were in that hypoinflammatory group that was the majority of the cohort, mortality was higher with high PEEP, and the opposite pattern in the hyperinflammatory group. So that was a little interesting, and that made us think, okay, well, maybe there's something here, that suggests these phenotypes are responding differently. What about another study? So we then tested a similar question in the FACT trial, which you may remember compared fluid liberal to fluid conservative therapy in 1,000 patients. Also published in the New England Journal, there was no mortality difference, which was the primary outcome, but there were more ventilator-free days in the fluid conservative arm. So here we asked a similar question: is there any difference in the effect of fluid therapy on death by phenotype? And once again, we found a very statistically significant result. So if you were in that hypoinflammatory group, again, the majority of the cohort, you did better with the fluid conservative strategy, and the opposite pattern in the hyperinflammatory group. So interesting pattern that we were starting to see here. And then we said, okay, well, hold on, maybe these patients are just sicker patients, right? Maybe this is something that we could see at the bedside and that the patients are overall more severely ill. But we didn't find any significant interactions with the Apache score for either PEEP or fluids. So it seemed to be something more complicated than that. Okay, so what about pharmacotherapy? So we collaborated with our friend and colleague, Danny McCauley from Northern Ireland, who had completed the HARP2 trial. Simvastatin for ARDS on the basis of some really elegant both animal work and early preclinical and human work that suggested that this might be beneficial. 540 patients, simvastatin 80 milligrams versus placebo. Yet another negative clinical trial, no difference in ventilator-free days or mortality. And this is the survival curve from that original New England Journal paper, where you can see simvastatin's just barely on top here, but no statistical signal here for difference. So when we stratified the survival curve by phenotype, we found something really interesting. So if you were in that hypoinflammatory group, it really didn't matter whether you were randomized to placebo or simvastatin. Those are the two blue lines at the top here. You tended to do fairly well. But if you were in that hyperinflammatory phenotype, if you were randomized to simvastatin, as you can see here in the red, versus the placebo in the orange, you had a significant survival benefit. Now, this is a secondary analysis, as nobody should go treat their patients with simvastatin. This needs prospective validation, but it gave more weight to the idea that there might be a treatment-responsive subset that's been hiding in this overall heterogeneous syndrome. Okay, we talked about how there's a lot of overlap between sepsis and ARDS. So then we sort of wondered, okay, well, are these really phenotypes of ARDS, or are they actually phenotypes that are more broadly applicable in critical illness? And so in work led by Dr. Pratik Sinha, who's a faculty member at WashU St. Louis, we asked if we could identify these phenotypes in sepsis. And we did this in 2 observational cohorts, one at Vanderbilt and one at UCSF, and then in 2 clinical trial cohorts, the Prowess shock study of activated protein C and the VAST trial of vasopressin versus norepinephrine. We started with the cohorts, and what we found is that even after we excluded ARDS patients, the latent class analysis again found that a 2-class model was the best fit for the data. And the variables that distinguished these phenotypes seemed to be very similar. We're still seeing these inflammatory biomarkers at the high end. We're still seeing bicarbonate, protein C, systolic blood pressure at the low end. And you can see here that even when we exclude the ARDS patients, we still see striking differences in mortality between the hyper and the hypoinflammatory phenotype. We then asked, okay, well, are these actually the same phenotypes that we saw in ARDS? And so we took classifier models that we had developed and trained based on the ARDS phenotypes, and I'll talk more about these in a few minutes. And we pointed them at these sepsis phenotypes to see if they were concordant. And what we found was really strong concordance, so that the areas under the curve for a variety of different classifier models were between 0.93 and 0.96. So there was a real strong concordance between the phenotypes we were seeing in sepsis and those that we had identified in ARDS. Okay, we then moved on to the clinical trials, Prowess shock and VAST, and you can see here that once again, mortality was strikingly higher in both of those trials for the hyperinflammatory phenotype here compared to the hypoinflammatory phenotype. But what was really interesting to us is that in the Prowess shock trial, again, testing activated protein C, we found a strong evidence of, again, this interaction or effect modification. So that if you were in the hypoinflammatory group and you were treated with APC, you did worse. And the opposite pattern was observed in the hyperinflammatory phenotype. When we looked at this differently here with the probability of being in the hyperinflammatory phenotype on the x-axis, because that's actually a continuous variable, not dichotomous, the way I've been presenting it, and the mortality on the y-axis, you can see that if you had a low probability of being hyperinflammatory, you did better with placebo than activated protein C, and the opposite pattern if you had a high probability. Okay, so this really suggests the idea that perhaps this hyperinflammatory phenotype might be a treatable trait that actually crosses over syndromic definitions. I've shown you this data in ARDS and in sepsis. Others have found this trait in acute hypoxemic respiratory failure. So maybe we should be thinking about using this as a paradigm for treating our patients. But everything I've shown you is retrospective, right? I haven't shown you any prospective data. Biology is really complicated, and if we think we understand these phenotypes on the basis of some superficial protein biomarker data, we might be completely wrong. And so we really need to test these hypotheses prospectively, which means essentially phenotype-targeted randomized controlled trials. But how do we do that, right? Here are the 3 patients that Dr. Matthay showed you in the global definition. Which one of these patients is hyperinflammatory, right? I can't tell you from these case descriptions. I couldn't tell you if I were just at the bedside examining them. So we need some way to be able to identify the hyperinflammatory patients in order to be able to target them in a trial. Now, I mentioned to you that we had developed parsimonious biomarker-based models that were able to identify the phenotypes with great accuracy. I'm not going to go into huge detail on that, but just to show you this figure, which is from the validation cohort in which we described these models, you can see that they can be really quite accurate with areas under the curve of 0.94 or 0.95 for identifying the phenotypes compared to the gold standard of latent class analysis. Now, it turns out that actually multiple models perform quite well. This table shows the top 6 variables that were the most accurate in classifying the phenotypes, and different combinations of these had areas under the curve in validation that were really all above 0.9, so pretty accurate. And I'm going to show you some more data on the models that use IL-6, soluble TNF receptor 1, and bicarbonate, because those are assays for which there are actually accessible real-time biomarker assays. These are 2 different devices that are both capable of measuring IL-6 and TNF receptor 1 in a clinically actionable time frame. On the left is one made by a company called Randox, and on the right is the Ella device made by Bio-Techne. And each of these can measure those particular 2 biomarkers on the order of a few hours, which is the type of time frame you'd need in order to be able to enroll patients in a clinical trial. And in fact, there are 2 studies that have just been completed in which patients have been phenotyped using this approach and these real-time biomarker assays prospectively in real time. One from Dr. Danny McCauley, shown here, the FIND study, which has just been completed with 525 patients, and one called the SPARK study, led by Clark Files and Laura Esserman and the iSpy network, of 320 patients. And I'm going to show you just a little bit of unpublished data from the FIND trial, which gives us some really exciting evidence that it's feasible to do this in real time. So this data was presented at the ATS meeting actually earlier this year by Kiran Reddy, who you see pictured here, postdoc working with Danny McCauley. From the FIND trial, which is this observational cohort from 20 sites in the UK and Ireland, with the primary goal of determining clinical outcomes in patients with ARDS based on prospectively allocated phenotypes using the parsimonious model that I just showed you, informed by a point of care assay. And I'm just going to show you this one slide, which is the primary outcome in ARDS patients, which was 60-day mortality. And so you can see that when patients, again, allocated in real time using those biomarker assays to the hyperinflammatory phenotype, or compared to those in the hypoinflammatory phenotype, you see we have this really striking difference of 23% difference in mortality, or an odds ratio of 2.6, highly statistically significant. And this is, again, confirmed in the survival curve, where you can see much better survival in that hypoinflammatory phenotype. So this data, which is being submitted for publication now, really indicates that it's feasible to do this within the time frame of critical illness, and in order to, which is really what we need in order to be able to do a prospective study. All right, so this confirms that prospective phenotype identification is feasible, that the phenotypes identified prospectively in ARDS have preserved prognostic value. So is it time to move to a clinical trial? Well, we think the answer is yes. I'm going to show you some data about the design of the Panther platform trial, and you can read more about it at the website you see here. But this is also being led by Dr. McCauley. It stands for Precision Medicine Adaptive Network Platform Trial in Hypoxemic Acute Respiratory Failure. This is an international phase 2 trial with real-time biological phenotyping. It is a platform trial, so therapies can drop in and drop out. Enrollment will be starting this fall in the UK and hopefully next year in the United States with support from the Department of Defense. The population will be adults with ARDS with either hyper or hypoinflammatory phenotypes. The first interventions will be simvastatin or baricitinib in comparator usual care, and the primary outcome will be 28-day organ support-free days. This is the design of the trial, and if you start at the left-hand side of the figure with me, you'll see adults with ARDS will be phenotyped using those biomarker-based assays and that parsimonious model. And then we anticipate a split of about 70% hypo and about 30% hyper. Both groups will then be randomized to usual care, simvastatin or baricitinib, and then we'll have adaptive analyses at about 240 patients in each arm that will allow us to stop the intervention when the results indicate either efficacy or futility, or when the arm reaches a maximum sample size. And this is going to be a Bayesian trial with Bayesian statistical triggers. Danny has brought together a really fantastic international group of folks working on this study. It's been funded in the UK and the US with applications pending in Canada, Europe, Japan, and Australia. And Danny is working hard to bring this also to India and sub-Saharan Africa. Now, I've focused on that one way of splitting ARDS, but as I mentioned at the beginning, there are lots of different ways to do this, and other investigators are working on similar approaches to precision medicine, but using different splitting strategies. So Ewan Gallagher is leading some of this work based on physiological phenotyping with the idea that high lung elastance may be a physiologic phenotype. I'm showing here the slide from his Blue Journal paper a few years ago that showed that the effect of higher tidal volumes versus lower tidal volumes is primarily evident actually in patients with really high elastance, which remember is essentially the Canadian inverse of lung compliance, right? And so Ewan is translating this along with Serena Sahatia, Eddie Fan, Neil Ferguson, and others into the practical platform trial. And again, the website's here at the bottom left. Which is identifying these physiologic phenotypes in real time, measuring elastance, and then stratifying patients by that elastance. And actually, Dr. Matthay enrolled a patient into this trial here at UCSF yesterday. Others are taking different approaches. So this is Lua Boss, who's leading the Pegasus trial, which is focused on focal versus non-focal ARDS, assessed with lung ultrasound. So lung ultrasound is being done. Patients are randomized after the ultrasound is done to either a control group in which conventional ventilation is applied or an intervention group in which personalized strategies are applied for focal versus non-focal ARDS in a sort of update of Jean-Michel Constantine's live trial from 2019. All right, so in conclusion, we may be at the precipice of this precision era in critical care medicine. This figure is from a perspective published in Nature Medicine a couple of years ago entitled Redefining Critical Illness, which posited that we are at the brink of a transition in critical care in when we may be classifying our patients based on their underlying biology. And I think we're almost there. We're starting to get to the clinical trials. So in summary, take-home points are that heterogeneity in ARDS may be contributing to the failure of clinical trials for novel therapies. Precision medicine approaches may help us identify subphenotypes within ARDS and/or treatable traits that span across critical illness syndromes. Hyper and hypoinflammatory phenotypes have widely divergent outcomes and responses to therapies in retrospective studies, but we really need to test this prospectively, and that's coming. So real-time biological, physiological phenotyping is being done in research contexts now, and hopefully these phenotype stratified trials are coming to an ICU near you. Thank you so much for your attention and for inviting me here, and I'd be happy to take any questions.
It's been a great lecture hearing from an expert in the field, and I think the conclusion is to still have answer questions. And we have a few questions, one in the chats, but I have one question about measuring the mention of the phenotypes, and if we look at Berlin definition. We don't have what we have in asthma or COPD now about IL-5, IL-4, IL-33, eosinophils, non-eosinophils. And I think it's a time, as you mentioned, there's a different phenotype. So the thing is, the driver is sepsis or DRDS. Is it time to think about adding some of the biomarkers that is really accessible to us in that definition? And another question for both of you too. We talk about pre-diabetes, pre-COPD. Are we going to talk about early intervention like pre-ARDS? Any, the lights goes on that we are heading into ERDS, and we don't have pathology to see that we are in the diffuse alveolar damage phase and the proliferative phase. Or we can start something a little more early ARDS that we can start adjusting our treatment or having a little attention to that phase.
Yeah, those are both great questions. Maybe I'll start with the biology-based question and then let Michael answer the question about early ARDS. I do think that we need to understand our patient's biology at the bedside. It's been really fascinating, actually, as we have gotten a couple of these devices in our lab and we have started to be able to measure some of these biomarkers in real time and see the patients in front of you and our own inability to actually predict which ones are going to have like relatively normal levels of these biomarkers versus extremely high levels of these biomarkers. And so the Panther trial is a step in that direction, right? We're measuring 2 biomarkers and identifying 1 phenotype. But of course, there's an incredible diversity of biology in these patients. And I do hope that within a decade or 2, we will be at a point where we can measure a wide diversity of biological markers in our critically ill patients beyond the clinically available lab tests that we have now, and use those to really inform our care of the patients.
Thank you so much, Carolyn. I have a question from one esteemed expert in the field, who is Dr. Prashant Naza, that you probably know. He asked, what about the challenges of PF for RDS diagnosis, for SPF VO2? This is for Michael, I suppose. And the challenges are even higher. So he's likely commenting that we have a lot of challenges in this in this new global definition. Would you like?
Well, thank you. I can try to respond and also incorporate the other question about early intervention. So the SF ratio does have limitations, as I tried to indicate, but it also allows us potentially to identify patients much earlier. So if we are trying to intervene earlier, and this, of course, includes areas of the world where blood gases are not available, the SF ratio is a reasonable alternative. And in the FRAT trial, the original classic high flow trial, it was not difficult to estimate the FiO2. So I think it's reasonable. And that study I showed from the CHEST article in 2015 was quite convincing. But the SF ratio oximetry is also an issue, and there's quite a bit of work being done now to try to improve its accuracy. So I think the SF ratio is a reasonable approach. It will allow us to enroll patients earlier in trials, but we need more studies also of its accuracy in comparison to PF ratio.
Yes, about that, I would ask you something about the treatment. So, do you foresee that adopting the global RDS definition could reduce the variability in RDS epidemiology across regions? For example, if I have a post-surgical patient with hypoxemia and bilateral infiltrates, now meets probably the global RDS, it is possible that this patient meets the global RDS definition. So should we manage like RDS, for example, proning a post-surgical patient, or is just for early recognizing?
Well, Dr. Battaglini, that's a terrific question. There is this new study in JAMA Internal Medicine that we wrote a commentary on for, awake prone positioning that argued that it might be beneficial in non-intubated patients. So that is a possibility. And that patient you described in the post-op setting, of course, we'd want to rule out fluid overload or left heart failure. But I think it's reasonable to think of that as a form of ARDS. But like Carolyn said, the other issue is what is the biology in those patients? So maybe a prospective study of that group with biology could be helpful.
Yeah, I agree. So, Dr. Calfee, one question for you. They asked if your patient has a hyperinflammatory RDS, what do you do at the bedside today? And if steroids, which and at what what dose and how long?
Yeah, that's a really great question. And I just got off of a week in the ICU actually, and was taking care of some very sick ARDS patients and wished that I had enough information to know how to treat them differently at the bedside right now. But I don't think we have that yet. Everything I showed you is retrospective, and I'm personally not comfortable changing anything in terms of treatment for my patients. And I don't think we should be changing anything until we have prospective data that confirms that we need to treat these patients differently. We hope to have that data relatively soon in the Panther study, but I think we need to test it prospectively before we can change our care for our patients.
Yeah, I might add to that, as Carolyn is indicating, there are prospective trials ongoing and about to start to test steroids with an effort to try and identify subgroups that might respond and subgroups that might be harmed. So I know it's tough to give a certain recommendation, but we do need more data, like she said.
Thank you, everyone. And I will just ask one more question from our LinkedIn Live community. This is from Assistant Professor Mohammed Megri. Said, thank you for sharing this insightful work by expanding the ARDS definition to include non-intubated patients on high-flow nasal cannula. How do you see this affecting our clinical practice? Most evidence-based interventions, such as lung protective ventilation, high PEEP, driving pressure limitation, and proning, have been validated in intubated patients, while awake proning and other non-invasive strategies have shown limited benefit. How should we bridge this gap in management?
Well, just very briefly, I would refer to that published article in JAMA Internal Medicine, and we wrote a commentary on it for use of awake proning in a summary of several clinical trials. It's quite favorable. It was focused on COVID patients, so we do need more data. But I think proning may be applicable as one supportive measure while we're waiting for more specific pharmacologic therapies in these patients who are not intubated, whether they meet the criteria exactly for ARDS or not. I think it's a really ideal group to study more around the world.
Thank you so much, Professor Matthay, and thank you, Dr. Carolyn Calfee, for such an insightful presentation. And due to everyone's time, on behalf of the SCCM ARDS Innovation KEG, Dr. Bushra Mina, and our moderator, Dr. Denise Battaglini, and of course, our distinguished speakers, Dr. Michael Matthay and Dr. Carolyn Calfee. Thank you so much for joining us today. This webinar will be available on demand across our channels. Please share today's session with your colleagues and follow SCCM and ARDS Innovation KEG for updates on future events. We look forward to continuing this global dialogue on ARDS. Thank you, everyone, and have a great day. Thank you so much.